FDA, which is called Drug Administration, recommends to have a dose counter to give a feedback. So here's an example of DBI, which is Spiromax. It looks like an inhaler, meter dose inhaler, but the internal configuration is different than the inhaler. And this is used a 3-step: open, breathe, and inflow. And here's a study that tests the uniformity of dose consistency when using Spiromax, and found that it can generate a consistent dose. Devices will focus on optimizing enhanced drug delivery and promoting adherence to therapy. Despite development in aerosol therapy, there is still need to reduce the cost of new aerosol devices. And most of the study that I encountered is in vitro study, so there is more need for in vivo study to study the effectiveness of these new aerosol devices and the
or lessen the disadvantages of secretion in the airway. So, when would you use it? When you have a large amount of secretion, more than 30 mL per day, or you have difficulty expectorating it, when you have an artificial airway present with this large amount of secretion, or if this second type is breathing techniques. There are 4 major types of breathing techniques: direct cough, which is using a cup with the glottal closure. There is inspiratory force, using the inspiratory muscles of the thorax and the abdomen, then cupping. The other type is forced expiratory technique. It's cup with the glottis open. The third type is active cycle of breathing, where we use diaphragmatic breathing, followed by a huff. The fourth type, which is pathogenic drainage, the increased cases of diaphragmatic device causing expiratory pressure ranges between 10 to 25 centimeters of water. Based on the angle of the pipe, the patient will generate vibrating frequencies around 15 Hz. The other type is an a cappella, which does the same function. It looks like a football. The other type is the whip. It has an angle the patient can rotate softly that will patient prefer. So they found out the patients preferred pathogenic drainage compared to active cycle of breathing. But they also, when they compared or asked the patient, they preferred active cycle of breathing compared to other oscillating devices and high frequency chest wall compressions. But at the end, none of them had a more significant advantage in terms of quality of life, exercise, or sputum or oxygen saturation. When they looked at pathogenic drainage, systemic review in 2017 looked at 21 studies. They found out that pathogenic drainage was preferred compared to other.
So imagine this patient is going from carditis, the small carditis, mechanical ventilation, the deposit of the mucus irritation, and blood is, and they will come to the mucus gland. So we will come to this one. So when it comes to the mucus gland, this is one of the challenge that we, again, put the capture concept into a contest here. You will find it's very hard, right? Okay, so that's why sometimes we need to increase the expiratory flow rate and let more air in there. Let think of moving them zero. I want you to remember when we move patients, not because we need to mobilize patients. No, we move patients because trying or hoping the air goes behind, or the respiratory flow goes behind the mucus, or blood or mucus, or to reopen the airways, hoping to build pressure behind the secretions to be down. We don't need to create such accumulation goes up to 71 because of the mucus problem. Okay? Shall I say the evidence? Of course, if you look at different modalities, I think CBT needs to retire from the practice. This is something I believe. No difference when compared to other modalities. It's just what is the best modalities for that population patients.
Yes. You put a clear statement that incentive spirometer is not good for prophylactic.
Yes.
And I really have been working 25 years in respiratory.
Yes.
When you have a patient who has long bedridden, he has broken legs and traction for 2-3 months on the bed.
Yes.
From my experience,
yes,
giving him incentive spirometer is like a magic. You see, when we talk about gas exchange and passive electrolysis, it is related to the position itself, and we cannot really move.
Okay.
So, please excuse me by saying that IS will help a lot in this area.
Well, and prophylactic uses when we go to the hospital and our students go into the surgical ward, before the patient even comes out the OR, there's an IS beside the bed. So that's when we talk about prophylactic use. Every patient coming out of an OR, let's just give them an IS and hope that that will open the lungs and will not retain secretion, minimize a lung infection in the hospital. And that's what the guideline means. It does not. In the example that you gave, that's not a prophylactic use. You have a patient who's not moving, not mobilizing in the bed. He has decreased lung volume and you want to improve it. So that comes out of the context of prophylactic. So it's not that incentive spirometry is not.
Magic solution in mechanical ventilation. You see, in mechanical ventilation, when we were using the jet nebulizer, we had a problem with the flow transducer. It was a tragedy. Now those people are not advertising to any company. I'm talking about Mish as the principle. It's really solving this problem. So I would like to be to know is equal to. Thank you.
Yeah, for the first question about the minimum residual volume or non-residual volume, for the study I did about it, most of them was in vitro studies, and most of them use a soda, which is active nebulizer. I think the passive nebulizer is enormously at the picture in the presentation. So maybe there is no minimal residual volume because I not read any study about passive nebulizer. Most of the study that I have encountered is about active nebulizer. So I'm talking about in general about the disadvantage and advantage of nebulizer, not specifically in each type of nebulizer.
Already, because all these. Mrs. Bashar. Yeah. Yes, I'm a little bit disappointed because all these modalities, the literature says that it doesn't make difference. So as I understand from your presentation, your recommendation maybe is to use the simplest and the cheapest method to for bronchial hygiene and non-clearance. Is that right?
12 points. Most of the literature, it's not that it doesn't support evidence, they're all weak. Even the recommendation, if you look at the guidelines, none of them are based on high, strong evidence. They are moderate to low strength. So in general, we don't have good studies to say that they work, but we do have our clinical practice to base it on. In terms of what modality you're going to use, the talk was about CPT. CPT, to be done well, is very time-consuming, and it needs an active participant, a clinician or a healthcare provider or someone to take care of the patient to do it. So in a normal hospital setting, if you have 29 treatments a day in a ward and you want to do 7, 8, 9 CPTs, you're not going to have enough time. You're going to do it in a very low
I was involved a while ago with groups of physicians from Russia and Turkey, and it was basically on the high frequency chest wall isolation and also the IPPV devices. Maybe those studies or those case studies that have been done in groups of patients were not published over the years, they have seen that even in non-traditional ways, like even for prognosis, they have used these devices and they found them, they are doing much better airway clearance than any of the devices. So I think it is just lack on our side in the region here for actually acquiring these kinds of studies that are showing the differences between, let's say, the high-end kind of airway clearance devices with the traditional original ones. But I think the literature I'm having is actually
throughout my lecture, I'm going to cover what you see on the slide, the definition of smaller ways, techniques to assess smaller ways, and more importantly, the physiological test, as majority of us are respiratory therapists. And then I'm going to present two of my studies that I was conducted during my PhD in collaboration with the University of Leicester and the University of Nottingham. The first one comparing the two of the most important physiological tests, and the other one a study using hyperpolarized helium MRI, which is an emerging imaging. We will be able to deliver the drug to the specific area for patient management. The techniques are consisting of two major categories: invasive technique and the non-invasive technique. For the non-invasive techniques, mainly it's the physiological test and the imaging modalities. However, for the invasive, it's only used for research purposes nowadays, because of ethical constraints. It involves using transbronchial biopsies and using bronchoscopy. This study was conducted at University of Leicester, and we found that indices derived from multiple nitrogen washout. These indices, namely the lung clearance index, which is an index of overall ventilation inhomogeneity, S-ascent, which is an index of ventilation inhomogeneity within peripheral, very peripheral acinar airways, and S-con, which is an index of ventilation inhomogeneity of conducting airways, all were abnormal in CF, as you can see, compared to healthy control. However, the indices derived from spirometry and plethysmography, which is namely FEV1, the ratio of FEV1 over FVC, and from plethysmography FRC plus and RB to total lung capacity, stay normal for those children.
Give you some of the latest and some of the evidence in terms of using vibrating mesh nebulizer, particularly as opposed to the jet nebulizer, which is probably kind of standard of care in most places, but it's an old technology. And I also want to kind of highlight the proper placement of the aerosol delivery devices with the various applications. So we have come a long way in our history of nebulizing. The first nebulizer was a compressed air nebulizer, invasive ventilation. So, for example, children are very difficult to deliver aerosol to, particularly when they're crying, for example. So we touched on the different types of aerosol drug delivery devices, and I won't overly go into these. So these are the metered dose inhalers. They were originally developed using CFC, but now that the environment is we're concerned about our environment, we've moved to HFA-based propellants, which I suppose is a good thing. We have the traditional jet nebulizer, which is probably the most widely used nebulizer. It works on a baffle system and it's been around a very long time. But nowadays we have other moments, and today I'm going to talk to you about the vibrating mesh technology.
Contribution in this symposium. Please welcome with me the Vice President of Academic Affairs of Imam Abdul Rahman Faisal University, Dr. Ghazi Al-Attibi, and the Chairman.
About the METANIP system. Me, Noor Bouchet, and my colleague Farah Abdel Karim and Najul Bouaisha will be your facilitator in this workshop. The METANIP system is considered a respiratory therapeutic device that used to mobilize secretions and to treat or prevent atelectasis. It's to provide three therapy in one, which is lung expansion therapy, secretions mobilization, and aerosol therapy. And how can I achieve that? I achieve that by three modes of therapy, which is first CPAP, which stands for continuous positive expiratory pressure, that provide lung expansion. I can combine this mode with aerosol. The second mode, which is continuous high frequency oscillation, which is usually such as a chest physiotherapy, try to mobilize the secretions inside the lung. And also I can combine it with aerosol. The only mode is aerosol mode. It will act as a nebulization. The advantages of this device, I can deliver it with oxygen supply, so the patients can receive the treatment with oxygen. The total treatment cycle usually it's alternating between two modes, usually CPAP with aerosol and CHFO.
I will have hands-on on this device, so if you don't mind, I'd like you to join me here to talk about this device. If you don't mind. I'd like to thank our valuable students, Ali Shawaf Mohammed Al-Hbeishi, who helped in setting up this station. So thank you very much. This is the METANIP device. It is a small handheld device. We can attach it on a ball, so we can mobilize it from one room to another. It is pneumatic, so no need for electricity. We can turn it on and off by only connecting it to certified 50 psi oxygen pressure. Okay? So either an oxygen cylinder or a wall outlet, it should be 50 psi, so this machine will operate. Okay? This is the circuit of the machine. It's a new circuit, so one volunteer, inshallah, eventually will try it on. We'll try the therapy. This is the filter inlet. This one is the expiratory inlet, and this is the flow line that will supply flow to the nebulizer. Okay? And here we have the small volume nebulizer, which we can administer medication and give nebulization treatment through this device. We will connect it here, and then we'll connect the flow meter. Inshallah, later on we'll apply it in a whole system, so you will be able to see it perfectly. This is the air entrainment port, and this is the venturi. Okay? The same concept with venturi mask. We will increase the resistance, will decrease the velocity, so we will increase the pressure of the air. So in order to achieve this continuous positive expiratory pressure. Okay? In here, you know the device, huh? We can, so I'll allow a lot of air to come inside. Two ducts mid-resistance. Okay? The air will be allowed inside, will be in the middle. And here, the highest resistance, the air inside will be low, so the resistance will increase. Okay? And I have here the mouthpiece, and this connection, we can use it actually with tracheostomized patient. Okay, so we can use it with the mouthpiece, with tracheostomized. With this connection, we can use a full face mask, but unfortunately, we don't have it here. So we will only apply the mouthpiece, exactly. Here, I can make sure that the small volume nebulizer is closed. I'll supply it with the flow from this oxygen tube. By the way, this circuit is a single patient use. It is disposable, but we can reuse it for the same patient for the duration of the treatment. So for example, this patient will receive this kind of treatment for 4 days. We can use it for the whole 4 days. It should be changed if the filter gets dirty. Okay? How to connect it? 45 degrees. We insert it, then we click it. It's secured now. We cannot remove it. Clear, guys? Clear? Ladies at the back? Clear? 45 degrees. We insert it. Now the device is ready to be operated. But for sure, I didn't apply the mouthpiece. How to perform a pre-use check on this device? We know that we shouldn't use any device before applying a pre-use check. Before you turn it on, you choose the mode, continuous high frequency oscillation. You choose the frequency to be the highest, and then you turn it on. Do you hear the frequency? By occluding the device, I should watch the pressure. It should be more than 15, not exceeding 30. And the pressure gauge. Do you guys see on the pressure gauge, ladies? Do you see? It should be more than 15, not exceeding 30. Okay, I made sure now that my machine is working. I should make sure that my pressure, again, more than 15, not exceeding 30. Okay, in case if I have a nebulization treatment, I should be able to visualize the mist coming out of this nebulizer. Okay? My colleague Jude here will talk in details about the mode of this device and how do we operate it.
So let's assume that our patient here have a lung collapse, okay, atelectasis, and need to go through all the process of our treatment. The first option here we have is to start nebulization. So what you can do as a suggestion, you start to give your patient regular nibs through the mouthpiece. Give them a couple of minutes till the patient is relaxed and ready to go through the cycles. Your total treatment is 10 minutes. Okay? So let's assume we're gonna start with the 2.5 minutes, and then after that our cycle will start. We're gonna start with a continuous pressure, expiratory pressure treatment for like 2.5 minutes. Okay, we're gonna adjust the pressure with our sit to flow over here. You can see it. So adjusting your pressure will be based on the flow knob over here. And then you're gonna see your manometer level for the pressure. After that, oscillation over here, you can adjust the frequency with 2 levels. You have the first level, which is the high level, which is 230 breath per minute, or you can start with a lower, which is 130 breath per minute. So it depends on the patient tolerance, which frequency or which pressure you're gonna start with. Okay, so let's start now and give Ms. Faye here a nibs treatment.
We'll give you nebulization.
Yeah,
it's a normal
Aerosol.
Okay. So again, we're gonna give the nebulization first. After that, we're gonna move to the lung expansion therapy. The last step is that we're gonna move to the oscillator therapy, which is gonna break down the secretions. Anytime the patient wants to cough and expectorate the secretions, he can do it. Okay?
One more thing is that with the PEP therapy, you're gonna adjust your resistance from here. If the patient cannot tolerate high resistance, which mentioned here with the 3 dots, start with the lowest resistance, which is the 1 dot. Okay?
You will make sure that the mesh is out.
The what?
Missed.
Yes, now we can turn it on. So we're gonna turn on the device.
Yeah.
And then this is, this is nebulization treatment, just regular nubs.
Yeah.
Okay? Give a patient, your patient, yeah, go ahead, you can just place it.
Breathe in and out through your mouth.
Normal breathing, just like regular nubs. We're not doing anything here other than regular nebulization. You have the options to give a bronchodilation, for example, or mucomist, just to loosen or bronchodilate your airways. Okay? So now the patient is comfortable to move to the second phase, which is the lung expansion therapy. Okay? I'm gonna start with a low flow, which means a low pressure, but I'm gonna move on to the pressure therapy. So now it's a low resistance. This is the lowest resistance. Try to see if this is suitable for the patient or not. Is the patient tolerating or not? The only thing is that the pressure from the device gonna expand the lung. Okay, so you're gonna spend here another 2.5 minutes to expand the lung. It's only a pressure over here. You can see the pressure amount through the manometer over here. Okay. Okay. So let's assume 2.5 minutes already passed. We're gonna move to the high frequency phase. I'm gonna start with the low frequency. Sorry. That's fine. That's fine. Anytime the patient cough and take his secretions out, he can do it. Okay. So now you're gonna feel the pressure of the frequency. Okay. You ready, Faye? 130 breaths per minute. It's the oscillation.
Okay.
Okay? Yeah. Go ahead now. As well, in the high frequency, the patient will breathe normally.
Okay.
Okay? There you go. Okay. One more thing, if you notice, the aerosol is working through the 2 modes. The aerosol is still continuously working through the lung expansion mode and the oscillation mode as well. Okay?
Do you observe her? She's oscillating. Yeah, this is the way of airway clearance.
So now what you're doing, actually, you're shaking her chest to mobilize the secretion in order for it to be out, ready to be out. Okay? So another 2.5 minutes in this mode, and then you're gonna again do another 2.5 minutes over here, another 2.5 minutes over here, and a total of 10 minutes, and your treatment is done.
أنا بشتغل في Origin as a clinical manager for the Middle East, and we are here just to show you the technology and maybe talk a little bit. So if it is okay, I will talk in English because that is my medical language. I cannot speak in Arabic except for a little bit, but if there is something that you cannot understand or you want me to maybe translate it into Arabic, I'm happy to do it. But we are here today just to talk about, I'm not talking about Origin only, but I'm talking about in general about nebulization and see why actually mesh is different or Origin is different from what we are. So to go back into history and how Origin came to this world and how it was actually all driven by the need that the owner of Origin had to develop something during critical care cases. The biggest challenge they face, or they used to face, hopefully they will not, with patients on ventilators, whether it is pediatric, adult, and neonates is even more because in most of the time they use high frequency ventilators, is the conflict that takes place between the flow coming from the nebulizer and the flow that is driven by the ventilator. And that actually force the clinicians, the RTs, the nurses to make so many adjustments. One of the adjustments maybe is to disable the flow sensor because it will be damaged. And if it is not damaged, the expiratory valve might be getting broken. So lots of challenges was facing them in the ventilators business or design. So the owner of Aerosol, he was actually one of those engineers doing the activities to improve actually the nebulization process using, because I think the technology before was still using the jet nebulizer. Now, if we go to jet nebulizers as they are nebulizers that have been on Earth for the last 60 or so years. Colleague Paul, he has actually shown the evolution of the nebulization or nebulizers over the years. So this is something that has been exactly the same since 1960 or 1955. Nothing has changed. It has to be driven by gas, and it has to be filled to a certain volume first before you run. It has to produce noise, and it has to run on a gas and with a flow meter that is at least with a 6 liters per minute. That was actually and it is still used in many countries, in many hospitals, and even now, one of the first countries that has taken this into their critical care departments, especially among Ministry of Health hospitals, and it is today, not this one, sorry, our nebulizer. And they changed the way they are working with critical care cases, especially in neonates. Why neonates? Because in neonates, they have specific low volumes of drugs. They are run normally with high-frequency ventilators. They cannot do without high-frequency ventilators, and they need a nebulizer that can match the high-frequency ventilators. Now, over the years, Aerosol came, and Aerosol today is maybe the innovator, not maybe, they are the innovator of the mesh technology. What is the mesh technology is all about? Mesh technology is actually, mesh is what you have seen, let me see. Okay, so it is just a small plate that has, a metal called palladium. Why palladium? Because palladium has special characteristics that actually fit into this in terms of, let's say, elasticity, in terms of solidity, in terms of compatibility, and so on. And this is a mesh, this is a plate that has 1,000 holes. So you can imagine 1,000 holes. You can actually do everything you can, but you cannot see it with normal eye. You have to take under a microscope, an electron microscope to see the 1,000 holes. And these ones actually are the ones that make the pump. So what happens when you put the fluid on this, the mesh or this plate starts to vibrate at a rate of 128,000 times per second. Can you imagine somebody doing this 128,000 times? Why at the beginning, and maybe you tell me from what you heard in the lecture, why nebulization? Why not intravenous for drugs?
Fast acting. Fast acting.
Okay, one.
Localize.
No.
Localize.
Localize, that means we are targeting the organ that has the problem?
Yes.
Okay. Okay, exactly. So it avoids all of the systematic side effects. And as you know, lung as an organ is the least organ in our body that you can play with. Okay? Even in surgeries, even in whatever, they don't have wires going in like they do with the heart, like they do with the kidney. It is the least organ that you can play. So the way to do this is to treat the problem in the heart, whether it is a fibrosis, whether it is erectiosis, whether it is whatever, you need to act on the organ. Because patients are not fit because they have nephrology problem, they have a liver problem, and we don't want them to have, besides the respiratory problem, another problem. Correct?
Correct.
So we bypass this and we do it to the, and also in one of the most important things is when you try to deliver drugs through directly to the lung, you can use higher doses of drugs. Now, one of the obstacles that they face today with nebulizers, and this is that they are not able to reach to the lower part of the lung. And this is not because, so if you have patients and you start to see these patients are not responding one time after one time of nebulization, you think that maybe you are not giving correct drug, you are not giving correct volume, but actually you are not making the drug reaching down. Because these nebulizers, this one as what we call a jet. Jet is a nebulizer that runs by gas or air from the wall. And that is exactly what is the jet term is, like jet flight, jet aircraft. So this has to be driven by gas. And the gas is normally a 6 liters per minute flow. 6 liters per minute flow. You cannot run nebulizers for less than 6. It will not be powerful. And this flow is what we call a turbulent flow. Turbulent flow actually makes the deposition takes place on the first entry point. It does exactly like this action. Okay? So it goes and drop and put the droplets on the first point of entry, which is the upper. That means we don't really see the patient responding. Okay, give him another nebulization. No, he's not. Then this is what we call it back-to-back nebulization, and it's happening so frequently in emergency departments. And it is nothing wrong with what they do because they are trying to avoid, but it is because the molecule sizes that are produced by this are actually not good enough to penetrate into the lower airways. So what we did in Aerogen, or what the inventor of Aerogen did, he wanted to go over all of these problems: noise, bigger molecules, requirement for gas, and he produced this technology. Now, one of the biggest issues that they face in this, I would not say they don't see it maybe, they need to fill the liquid first to a certain volume before they start and then add the volume. Okay, so if the doctor tells you, give this patient 3 ml, 2 ml drug, 1 ml saline, you put 5 because the other 2 actually is something that will stay here and without it you cannot run, correct? So in this one, there is none of these issues. We have no noise. We don't need to fill the drug for. I will connect it. Okay. So here I just show you that even if I have one drop, I will have the nebulizer work. Okay. So the nebulizer. This is not the nebulizer. This is the mesh, but I will show you. So with one drop, I'm able to run the nebulizer, which means I will run the nebulizer all the way until there is nothing left. Okay? And this is the mesh that we have in our nebulizer. So this is our actual nebulizer. And the mesh that I demonstrated to you there is inside here. And this is the chamber where actually we put the drug in. So this is our nebulizer. This is the nebulizer. So here we solved the problem of noise. And that's, did you hear any noise?
No.
We solved the problem of running the device. We don't need, this is okay, but we also can run it because in certain hospital environments, you have ventilators, you have monitors. You can run the nebulizer by this cable, which is connected through a USB. Ventilator, monitor, it doesn't really matter, but I'm connecting here to a power bank. And this one, if I put it into our nebulizer, okay, some people are already smiling. Maybe there is something there. I will put some. Okay, and I switch this one on. Okay, so what I have here is a nebulizer that is not running on any source. Quiet, and also it is very fast. The normal nebulization that will go by this normally for one therapy is 15-20 minutes, right? Maybe 10-15 minutes, whatever. Nebulization. Because we have small molecules here, 1 to 5, in most of the cases where this is used today in hospitals, they don't do back-to-back nebulization. So they do one nebulization, discharge the patient, or make assessment, discharge the patient. Because if you try to do what you do here, you will give patients too much drug. And too much drug of Ventolin is not really harmful, but it has some side effects. Ventolin or any bronchodilator is a safe drug, but it has side effects. Side effects like tachycardia, toxicity, patient starts to shiver. These these symptoms or these side effects are completely avoided when you reduce the dose and when you reduce the times of nebulization. Now, we started, as I said, in mechanical ventilation or in intensive care departments, and that is why we have developed these T pieces. So on a ventilator, and it can go, for example, here. Okay? I'm not sure if it's on, but this is for ventilators. Now, here we have adult, but we have also pediatric and neonate adapters. Okay. Yes.
I have a question. Does it matter if we put the mesh nebulizer near to the patient or near to the patient?
It doesn't. It doesn't, and I wanted actually to comment there. Even if it is this distance away, does it make a difference? This is going to work as your spacer. This piece of circuit will work as your spacer. It doesn't really matter. However, as Dr. Paul said, we really don't have any even, reason why it is showing more deposition here or there. But from the logical point of view, it should not matter. Even if you have it in the way. Our recommendation is to make it, if you have HME filter, for example, make it after the HME filter. Okay? But it has to be the last entry point. So it doesn't really matter. So, back again, this one, and without light it is difficult too. Okay, this is for intensive care. This is for intensive care. Now, when patients start to become spontaneously breathing and you need to continue the therapy away from the ICU, we have developed a set called the Ultra, and this is our spacer. Okay? Now, our spacer here is not only a spacer, but also it is a reservoir. It will reserve. And if you start to use this in your hospital later or for those, okay, this, if you put it here, it doesn't actually, so if you get used to this, the smoke is coming all the time, it is not here. It reserves it until the patient is able to breathe and will take the breath from this inside. So the patient is breathing either through the mouthpiece, which is the best way of getting the drug into the patient, or the mouthpiece.
Mask.
Yes. The mask. Now, if the patients, for whatever reason, are not able to take the breath, or you want to really to give them supplementary oxygen, then only you can connect this to an oxygen tube, and this is all the way is one-way valve. Okay, so it will not actually, you will not need to do wash out of CO2 later. Okay, and here you can actually give a little bit of push, but here the source of gas is not to drive the nebulizer. It's just to help the patient getting in. And for COPD patients, it is safe to do it with this because 1 liter per minute of flow is good enough. It is not harmful for COPD patients. Okay? So this is the spontaneous breathing kit.
واخواننا اخواتنا today في عندنا شيء اسمه lung expansion therapy. احنا الان بدنا نعرفكم على النيو ميثودولوجي اوف lung expansion therapy، ونحن متاكدين انه اذا استطعنا نستوعبها ونعمل فيها وننصح فيها مرضانا ستؤدي الى نتائج جيده وجيده جدا. الطريقه اللي كنا نستخدمها وتعلمنا عنها في المدرسه اسمها اللي هي عباره عن البيب، اللي هو هذا هو البيب، شايفينه؟ هذا البيب. هذا البيب قضيته سهله جدا. مريض عنده COPD بخفف من الاير ترابلينج، لما المريض بيعمل اكسليشن بيعمل لي باك برشر، بيعمل اوبننج للاير، بساعدش السكريشن كثيرا. انتبه الى هذه يا استاذنا، ما بساعد السكريشن كثيرا هذا. حتى يساعد السكريشن كثيرا اضافوا اليه شيء سموه الكابيولا او سموه اللي هو هذا عباره عن ريزيستنس للاكسبيريشن وبيعمل 1000 هزه بالثانيه. هذه الفريكونسي لما تيجي بتعمل اكسليشن بهذا الشكل بتوجد كل الموجود عندك من الداخل اهتز واصبح بطريقه ممتازه. هذا الحقيقه انا وجدته رائع وجميل، لا اعمل له دعايه وسعره معقول جدا. هذا اسمه الاكابيلا، وتعرفوها الاكابيلا مثل نفس المبدا بتاعها.
وهذا هسه بس تيجي عندي هتشوف انه هذا افكتيف عجيب. هذا حتوجدوا انه افكتيف عجيب. الاكابيلا فيها نقطتين انا بس بدي اقولها. البرشر بقدرش احدده هنا، البرشر فيه زائد وناقص، هنا بقدر احدد البرشر من خلال 4 سرعات موجوده عندي حاورجيكم اياها. النقطه الثانيه هذه الاكابيلا بتشتغل اكابيلا وهاي فريكونسي، بينما هذا ممكن يكون بيب تو ستابلايز اونلي، وممكن يكون ايضا فور سكريشن من خلال الباراميتر. ممكن احط معاه نيبيولايزر، والاكابيلا بحط معاه نيبيولايزر، صحيح؟ لا بحط على كابيلا. وقف عندك، وقف عندك. هاي الكابيلا هنا بحط النيبيولايزر، شايفها؟ ابو العبد، هذه الكابيلا وهي النيبيولايزر وسلامة سلمى. قولا واحدا لا خلافه، جربها وشوف. ابد، تعال عندي، هيا فاعطيني نيبيولايزر، رد علي اخوي، تعال عندي تعال عندي تعال عندي. هذه الكابيلا، الكابيلا انا باخذ منها نفس، هيو قاعد باخذ النيبيولايزيشن الان، باخذ النيبيولايزيشن الان. بعد ما اخذت النيبيولايزيشن وانبسطت وصار عندي برونكيال بعمل، فانا عملت كومباينيشن بين الايرسول والاكابيلا. شايفين حبايبي؟ شايفين حبايبي هنا مش هنا؟ حبايبي شايفين؟ اخذت الايرسول، هذه الاكابيلا. سيئة الاكابيلا بالنسبه لي انا ما بقدر احدد البرشر، هذا في زائد ناقص. السيئة الثانية استاذي من وجهه نظري انا، الاخ مساعد رئيس القسم في مستشفى الملك فهد الجامعي. حبيبنا وين المصور؟ بعدين ما بقدرش انا اعقمها. هذه صعب، هذه بالذات النوعيه هنا ما بتنفكش اخوي. في بعض النوعيات ممكن تنفك هي كلمه سنجل بيشنت يوز ممكن تقعد سنه سنتين 3 4. هي ما سنجل، يعني ما بستخدمها انا مريض ثاني، بس هي مريض عنده شويه ودي تقعد عند العمر. هذه يظن 15 minutes. ايوه 15 minutes. اوكي اخواننا اخواتنا، هذه اللي بدي اعرفكم عليها الجديده. هذه عباره بسموها ريسبايت بلس. الار سي كورنت بلس تغلبت على المشاكل اللي موجوده هنا والمشاكل اللي موجوده هنا. كيف تغلبت عليها؟ من خلال انه وضعت لي اذا وضعت على سرعه واحده، السرعه الاولى كيف وضعها؟ شايف هذه الماوث بيس، هذه الماوث بيس، في عندي ثقب واحد، هذا سرعه اولى، وفي عندي سرعه ثانيه اللي هو ثقبين، سرعه ثانيه ثقبين. برجع الى سرعه واحده والبرشر بتحكم فيه من هنا. هذا 5 في سهم 10 15 20، احنا بنحط من 10 الى 20. اوكي، فاذا انا ضبطتها بطريقه جيده. اذا حطيت سرعه رقم 1 زائد 5 هنا، معناها انا قاعد بشتغل فلتر ولا بشتغل اوسيليشن، بشتغل فقط على البيب اللي هو التقليدي القديم اللي مثل هذا. اذا وضعت سرعتين هنا زي ما بدي، كيف بتحكم فيه؟ الزاويه، وبدات اعمل اوسيليشن. الاوسيليشن سهل يا ابوي، حطها بثمك بدون ما تعقد المريض وتعطيني انستركشن زي ما بنعمل في الاكزامز. حطها كذا وتفرش عادي. بعدين الاكسليشن الان ما طلع الصوت، معناها هاي خرباني مش مضبوطه. هم خربوا لنا اياها البنات. خلينا مشان ما نضيع وقت نيجي على واحده مش خرباني. هذه مش خرباني، البنات ركبوا هذه غلط، معناها خرباني. شايفين؟ برضه هذه معناها بدت عندي تخرب. السبب هذا سبب الخراب. هذا المفروض انه يكون داخل بطريقه صحيحه ومش مثني. شوف اذا انتنى ما اشتغلت. اوكي، حتى اشوف انه مثني او مش مثني ممكن اتفرج عليه من هنا.
مضبوط،
بين شكله مضبوط، بين
مضبوط.
معناها الوضع عندي جيد ويشتغل بطريقه جيده. خلينا نجربها مره ثانيه. بسم الله. كيف؟ هاي مرتين 3 4 5. فمن هنا بعمل 10 مرات وهي فعلا فعالة وفعالة جدا. بعد ما أخلصها البريد برتاح وبعمل
هاف كف
4 مرات اوكي، وبعيدها مرتين وثلاثه واربع مرات. فيري افكتيف فيري نايس. ان شاء الله بس تيجوا الان تشتغلوا معي نعرفكم عليها بطريقه جيده.
واخذ لك حل
specialist hospital and Hashim al-Awami level 4 students. Okay, they will help me in this one. Today, inshallah, our workshop about hemodialysis and bronchial hygiene therapy. كنا نعمل presentation نروح عليها hands on. فبطلنا ايش؟ نعمل hands on more than presentation. Here in our session we talk about the hemodialysis who are high frequency chest wall distillation and cuff assist or insufficient. This is it's considered of the new modalities and the bronchial hygiene.
تعرفوا ايش اسم هذا الجهاز؟ قد شفتوه؟ ايش اسمه؟ كف اسيست. طبعا هو ميكانيكال انسفليشن اكسفليشن. حلو؟
تدري ان هذا عندنا في التعليم؟
احد شافه في التعليم يا اخي؟
لا
مسكر
مقشوش لطيف 20-30 راح يطلعوه
فساد.
اوكي من الخلف عندنا الكتريك واير، ومن الجانب عندنا بكتيريا فلتر وتيوب، ومن الانترفيس سكرين راح يكون هذا بهذا الشكل ان سويتش ان اوف. عندنا 3 خيارات. المنيو هذا حق اعدادات المصنع ما نهتم لها في الغالب. عندنا السيتنج تعرفوها؟ اوكي. عندنا اول شيء بريست اعدادات مسبقه البيشنت يحطها اساس يختار لك يرتاح لها، هو يحط المود ويحط السيتنج قبل. تمام. سكند المود عندنا اوتو ومانوال. اوكي. اند اكسهيل برشر. حلو. تمام. وطبعا التايم في المانوال كيف نتحكم فيه؟ حسب فور انهاليشن فور اكسهاليشن. تمام. الحين راح المود الثاني راح يكون الاوتو طبعا عندنا اللي هو زياده الفرق بينه وبين المانيوال انه في تايم انهيل تايم اكسهيل تايم وفي البوز تايم. طبعا في عندنا حاجه زائد اللي هي كف تراك. ايش اللي هي كف تراك؟ حسب النفس. اوكي حلو.
دخل نفس.
اوكي زي trigger if the patient trigger the machine will give him insufflation and exsufflation and the therapy will be stopped. Okay, we'll switch on the cuff track and we'll start. طبعا setting initial setting what is the initial setting for brusher 10 brusher initial راح تكون طبعا في الاكسهيل راح تكون نيجاتيف وفي الانهيل راح تكون بوزيتيف. والانهيل تايم فور ادلتس راح تكون 1.5 to 3 سكند، والبيدياتريك راح تكون 0.5 to 1.5 سكند.
حلو.
الحين راح نجرب مع الكف تراك. Now to start the therapy, press the therapy insufflation exsufflation. We'll use the mask. There is no response. Why?
ما في تريجر.
Give the patient trigger. Okay, stop. No response. Give trigger here. That's the principle of track. Cuff track. Okay. Now we'll stand by to change the mode. We'll switch to manual mode. Manual mode and the manual mode will use if the patient يعني إذا البيشنت توه اشترى الجهاز بيجربه كيف يجربه يبدي بالانيشال مود من 10 ل 15 على اساس يتعود على الجهاز، بعدها ينتقل للايدري برشر اللي هي 35 to 45. تمام. راح نجرب المانوال فينش ثيرابي بس ثيرابي ستارت. اوكي there is no response. Why? Okay. Inhalation, insufflation, exsufflation. Inhalation, inhalation, exhalation. This is the principle of the manual, and now the principle of the pause should be off. Switch off the cuff track, and the pause time is 2 seconds. Now we'll give him continuous insufflation, exsufflation. Insufflation, exsufflation. This is pause period.
والله صح؟ هذا الأخ حياك الله والنعم. عشان كذا نبغى نجرب عليك عشان تقول للجماعة رحت أنا جربت الجهاز. ما حتكلم نظري كثير شباب. حنشتغل بشكل كبير عشان برضه زميلنا اسمي كريم. حياك الله. هذا الهاي سيلكتري just one أو الهاي frequency سيلكتري just one vibrator. The market there are mainly two machines from West from Hebron. بيجي ب two types 105 and 205. 205 يا شباب انتوا هذا مش موجود عندنا، موجود عندنا 105 هذا for hospitals. استاذ خالد this is you can the only thing difference that you can put it on a trolley بيجي مع trolley هذا بيجي مع trolley. other things it's
the same.
عندنا تيجي مع عندنا الفيست كلكم عارفينها، عندنا ريوزابل تيجي بالديفرنت سايز مثل هذه adults small، عندنا في also for pediatric and also we have هو الماكسيمم. عندي هنا هذه فيست for bronchoscopy patients وتشوف كيف السكريشن تبدا ايش؟
تتحرك
تطلع لوحدها هي لوحدها اوكي. الجهاز بسيط جدا يعني فريندلي يوز مثل ما يقولوها، ما فيها كومبليكيتد جاست يو كونكتد تو ذا الكتريسيتي اتس ويل ورك. اوكي انا حوريك بس كذا عشان ابغى هذا يا ريت انه تكتبوها ملاحظه انه يكون في سهوله الرجوع الى المين سكرين اسهل من قضيه ايش؟ هذا يعني في كونتاكت كومباني ذي كان دو ات. اوكي ناو الجهاز بيشتغل مباشره مجرد ما شبكته بيشتغل مباشره. تمام في عندي هنا بس تشتغل هذه شباب. خلينا عشان قبل ما يشتغل شوف عبد الله نبغى نلبسك ونجربك الجهاز عشان تقول انا والله جربت الجهاز
يقول حق الكليه
تيستد ذوقوا يعني حتى تعرف انه المريض كيف انت لما تعمل تريتمنت تنساه ايش راح يشتغل. فهذه الفكره كالاتي. ايوه هذا عباره عن ليست هذا كذا اوكي تمام. بعد ذلك شوف انا في عندي جهاز في عندي نورمال مود في عندي كاستم. الكاستم مود تو اوبشنز في عندي الرام انه تحدد فريكونسي وبلوينج وتايم. اوكي اتس ويل انكريز ويل ستارت with low frequency and it will increase gradually until certain اللي هو التارجت حقك بيكمل على هذا التريتمنت. ليش الهدف منها يا عبد الله عشان انه البيشنت تولرنس انت بتبدا معاه بهاي بريشر حتكون صعبه عليه احيانا فانت تبدا معاه بايش؟ شوي مثل ما نقولها خبز سنه ممتاز. فبالتالي المريض كان تولرنت. البروجرامينج انت لك هدف انه يبدا في بروجرام في فريكونسي معين for a certain time ثم we have here 8 program we can start with it ثم بعدين يدخل البروجرام الثاني يعطيه فتره زمنيه مثلا 3 حياخذ 6 لمده ايش توزعها 30 دقيقه اللي احنا تكلمنا عنها. كل واحد بيكون له فريكونسي اي كل واحد بيكونها وانت تقدر تعمل ادجستمنت عليها. حنبدا الان هنا هبدا طبعا هنا هذه تتشينج النورمال هنا حيظهر عندي هذا الفريكونسي هذا البلوينج هذا التايم. فانا الان حبدا ب فريكونسي شوي منخفض تعطيني شعورك. هنا البلوينج برضه حيبدا في منخفض تعطيني شعورك. وهنا التايمينج حزيدها ونشوف الوضع. طيب نبدا. شوف الان هذا الان هو الان نفخ بلوينج. لاحظ الان حزيد لك شوف الان زاد صح؟ زاد الضغط. هذا الان الضغط اللي حيسويه لكن انا ممكن اخففه. طيب الان ستارت يا ساتر. طبعا there is a very nice remote control
عشان لو صار شيء تطفيه.
ايوه الان احكي لي شعورك.
كح
تكلم ما تحب تتكلم. طيب الان شوف الان اوكي فيري نايس. لاحظ انه انت بعد شوي حتبدا كنت تشعر هنا شويه
نفس الجو
نفس
الفالبيشن
هذا جميل.
اضغط في هذا زيادة
تمام اوكي
اضغط اللي في يدك
الريموت كنترول بيدك تعبت طفي. اوكي
طفى طيب عشان
خلاص شايف نشغل مره ثانيه
اضغط ثاني وارجع.
هذا زي
والله شباب قلت ما تحب تجيبوه في المستشفى